respected delegates and my dear friend resident. Myself Dr. Abhijit. Today I will be talking on mediastinal vascular anatomy and its radiation. So we will briefly revise the mediastinal anatomy. The mediastinum is bounded anteriorly by the sternum, superiorly by the thoracic inlet, posteriorly by the dorsal vertebrae, inferiorly by the diaphragm. And again the mediastinum is divided into superior and inferior mediastinum by an imaginary line joining the sternal angle with the inferior margin of the T4 vertebra. The inferior mediastinum is again divided into anterior, middle and posterior mediastinum. The superior mediastinum contains mainly the superior vena cava, which is formed by bilateral innominate veins, the aortic arch and its three branches. Not going to all the contents of the mediastinum, I will stick to vascular anatomy only. So, the contents of superior mediastinum are the bilateral innominate veins joining to form the SVC, which courses into the inferior mediastinum and drains into the right atrium. The arch of aorta and all the three branches, main branches of the arch of aorta are the contents of the superior mediastinum. Then the middle mediastinum contains the heart enclosed in the pericardium, the ascending aorta, the main pulmonary trunk and its main branches, right and left main pulmonary arteries. Veins, SVC, which is formed by the azygous vein which drains into the superior vena cava is also the terminal part of azygous, and pulmonary veins is also the content of middle mediastinum. Now the posterior mediastinum, it contains the esophagus, the descending thoracic aorta and its branches. The azygous, hemiazygous and accessory hemiazygous veins are the vascular contents of the posterior mediastinum. So these are the coronal reformated MIP images from anterior to posterior. Here we can see on either side of the sternum lies the rima and lima, that is internal mammary arteries. Further posterior section will show the heart resting on the diaphragm with the origin of ascending aorta from the left ventricle. On left side to it is the pulmonary trunk. Then further posteriorly we can see both the innominate veins forming the SVC, which is draining into the right atrium. So coming to variations in the anterior mediastinal vasculature, the rima and lima on either side may come paired. Why we should know that is if we are planning for any biopsy of the mediastinal or anterior lung masses, then we must know the presence and location of the internal mammary arteries, as inadvertent injury to them may lead to devastating situations. So we will go from caudal to cranial. Here we can see both the right and left ventricle and descending thoracic aorta. Further cranially we can see all four chambers of the heart and descending aorta. Further cranially we see the widest portion of the ascending aorta, that is the region of sinus of Valsalva, with origin of left coronary artery very well seen in this section. This is the pulmonary vein. Cranial to it, if we go, we can see on the right side is the ascending aorta, the main pulmonary trunk dividing into right and left main pulmonary arteries, and posteriorly on the left side is the descending thoracic aorta. These are the coronary angiograms. The axial section here at the region of sinus of Valsalva, we can very well see origin of the left coronary and right coronary artery, and on coronal the left coronary artery giving branch as a left circumflex and continuing inferiorly as the left anterior descending artery. Now coming to the superior mediastinum, here we can see SVC on the right side and aortic arch, and in this image we can see all the three branches of the arch of aorta. We should grossly know the sizes of the aorta. The aorta is largest at the region of sinus of Valsalva, which measures approximately 3 to 4.5 centimeter. Then ascending aorta and arch of aorta nearly measures 22 to 36 millimeter in diameter, and descending thoracic aorta, which is tapering from top to bottom, ranges from 20 to 30 millimeters. Now coming to pulmonary arteries, this is the schematic diagram showing main pulmonary trunk dividing into right main and left main pulmonary arteries, further dividing into lobar and segmental branches. This is the axial MIP image of the pulmonary trunk, wherein we can see the main pulmonary trunk dividing normally into right and left main pulmonary arteries, further dividing into lobar and segmental branches. This is the DSA image of the pulmonary trunk, wherein we can see right and left pulmonary arteries dividing into the lobar branches. And these are the dedicated right and left pulmonary angiograms, which shows beautifully shows the entire vasculature of the right and left lung. Now coming to variation, the left pulmonary artery sling is the common variation we come across. That is, the left pulmonary artery arises from the right pulmonary artery. This is the pulmonary trunk giving right main pulmonary artery, from where the left pulmonary artery arises and courses behind the trachea, goes to the left side. Here in sagittal image we can see the sling indenting over the posterior aspect of the trachea. Now coming to pulmonary venous system, we know there are paired veins on either side which drains directly into the left atrium. This is the right superior pulmonary vein, this is the right inferior pulmonary, left superior and left inferior pulmonary veins draining into the left atrium. We have almost 5 types of variations in the pulmonary venous anatomy. This is the normal, that is paired on either side. In type B, we see there is a common stump, which is short segment common stump after joining of the superior and inferior pulmonary veins of left side. In type C, there is a common segment, but the segment is longer as compared to B. In type D, we see there is accessory right middle pulmonary vein. In type E, there are 2 accessory middle pulmonary veins, and type F, there is accessory superior and accessory middle pulmonary veins. Now coming to types of aortic arches, type 1 is the normal aortic arch, where there are 3 branches. First is the brachiocephalic trunk, then the left common carotid, followed by left subclavian artery. Type 2 is a bovine arch, in which there are only 2 branches of arch of aorta. The right brachiocephalic trunk, after its origin, it gives origin to the left common carotid artery, and the second branch is left subclavian artery. In type 3, there are 4 branches of the aortic arch. The first one is brachiocephalic, second left common carotid. The left vertebral directly originates from the arch of aorta, and the last one is left subclavian. Type 4 is a combination of bovine plus left vertebral type. That is, again there are 3 branches continued, but the left common carotid artery originating from the right brachiocephalic trunk. The second branch is left vertebral, and third is the left subclavian. Type 5 is a common carotid type. That is, the first branch coming is the right subclavian artery, followed by common origin of right and left common carotid arteries, and last one is the left subclavian artery. Type 6 is the aberrant right subclavian artery. That is, it should be originating as the first branch, which in this case is taking origin in the last and traversing from the posterior to the esophagus, traveling right across to the right side and indenting over the esophagus, which leads to dysphagia lusoria. Type 7 is the right-sided aortic arch. Here is the CT image showing right-sided aortic arch. The aortic arch is on the right side to the trachea and esophagus. the further caudal section of right sided aortic arch, wherein ascending aorta and descending aorta are both on the right side of the trachea and right mediastinum. This is the ARSA, that is aberrant right subclavian artery, which is taking origin after the completion of arch of aorta or proximal portion of the descending thoracic aorta. It courses behind the esophagus, indenting over the esophagus, as I have told. This is again an ARSA, but it is aneurysmatically dilated ARSA. Now, importance of the ARSA detection in ANC scans. As Bimal Sahani sir told, ARSA can never be seen at the level of 3-vessel trachea view. If you see any arterial trunk which is at the level of 3-vessel trachea view, you are dealing with the ARSA, which is coursing behind the trachea and traveling to the right side. So, this is a double aortic arch, wherein the arch of aorta is split into right and left half, coursing around the trachea and esophagus, posteriorly joining together to form the descending aorta. The right arch will give branches of right side, that is right subclavian and right common carotid, and left branch will give origin to the left subclavian and left common carotid. This image A is a very typical type of double aortic arch, which is symmetrically rounding around the trachea and esophagus, giving appearance of a donut. And the image B is showing a dominant right-sided aortic arch in this double aortic arch case, wherein the right-sided segments are larger as compared to the left portion. Now, coming to mediastinal venous anatomy. In superior mediastinum, we have seen both the innominate veins joining to form the superior vena cava. On the right side lies the azygous vein, on left side lies the hemiazygous and accessory hemiazygous veins, both draining into azygous and going to join the SVC, which will drain into the right atrium. Here is the image showing superior vena caval duplication, that is the left superior vena cava is persistent, and we can see both the vena cava on either side of the mediastinum. Now, the on right side of the aortic descending aorta lies the azygous vein, and on left side is the hemiazygous vein, which are dilated in this case of cirrhotic patient. Now, coming to bronchial arteries, these are the arteries taking origin from the descending thoracic aorta at the level of T5, T6 level. We all know there is only single bronchial artery on the right side, and there are two bronchial arteries on the left side. The right bronchial artery takes origin from the intercostobronchial trunk, that is ICBT. The bronchial venous anatomy, the right bronchial vein drains into the azygous vein, the left bronchial vein drains into the accessory hemiazygous, which will join with the azygous and drain into the SVC. Now, coming to the last slide, that is variations of the bronchial arteries. Type 1 most commonly seen in 41 cases is the right bronchial artery taking origin from the ICBT, that is intercostobronchial trunk, and there are two left bronchial arteries taking separate origin from the descending thoracic aorta. Type 2 counting for 21%, there is only left bronchial artery, that is single left bronchial artery on left side, and right is originating from the ICBT trunk. Type 3 counting for 20% of the cases, wherein there are paired bronchial arteries on either side. Main right bronchial artery taking origin from ICBT and accessory artery taking origin directly from the anteromedial aspect of the descending thoracic aorta, and there are two left bronchial arteries. The least common, counting for 10%, is type 4, wherein there is only one left bronchial artery and there are paired bronchial arteries on right side, one taking origin from ICBT and another directly from the aorta. These variations are very much required in the IR practice. When we deal with the bronchial artery embolization, we must consider all these variations so that we should not miss the bleeder, and we should get the 100% result in case of the bronchial artery embolization. Thank you so much for your patient listening.
Thank you.
I would like to thank organizers for giving me chance to give lecture in this first ever Marathwada RadCon. Thank you so much.
Thank you, Dr. Abhijit. You have nicely depicted all the anatomical variations which are must for the IR radiologists, interventional radiologists. But these can be diagnosed by all, these should be known by all diagnostic radiologists as well, because these can be your creditable points to give them a roadmap while doing interventions. So very nicely done.
But it is very difficult to see the bronchial arteries on CT, as their diameters are just 1.5 to 2 millimeter.
Probably on DSA machine while doing angiogram.
While doing all, it is. Yes, thank you.
Thank you, sir, for such a wonderful talk. I request Sunil Vakil, sir, to felicitate Dr. Abhijit Nagapurkar, sir.